Our next session is recurrent vomiting. Presenter is Dr. Vibhor Borkar. Moderators Dr. Ujjal Poddar. Panelists Dr. Priya Kishnani, Dr. John Matthai, Dr. Archana Kher.
Welcome back. The moderator remains same for this session also, but our panelists are different. We have Priya, we have Archana, and we have John, three learned panelists. I am a novice in this case. This is a metabolic liver disease, so I don't know much. We'll start the presentation and we'll discuss as the patient goes. Instead of just discussing the diagnosis, we'll go step by step how to interpret different information. Vibhor, can you start?
Yeah. So our case is a 1.5 years old boy who was brought with complaints of, actually he has a history of 4 discrete episodes of intense vomiting, which was followed by respiratory distress and lethargy. And when this event was subsided, he was in between completely normal, and this event was always preceded by a febrile illness. So let's go through in details how these events had gone. So these are the few typical episodes. So it started at around 9 months of age. Every time there was a fever, followed by he had a vomiting, which was non-bilious, not associated. So, so each time the typical episode we have seen, there was a vomiting which was 8 to 10 times per day. It was non-bilious and not associated with abdominal distension or constipation. There was lethargy, and every time he was admitted, he has received IV fluids, and you can see in the 2 to 3 days he improved. After that, he was asymptomatic. This child was born of a third degree consanguineous marriage, was developmentally normal. In between the episodes, he was asymptomatic, and was the negation of the milestones after each of these episodes. And we can see these episodes recurring every after 2 months. So there are further few of those episodes. In one of the such episodes, he has generalized tonic-clonic seizures. He has acidotic breathing, and on investigations he found to have a hypoglycemia, for which it was corrected. He received IV fluids, received bicarbonate corrections for the acidosis. At that time they found that he had also urine ketones positive. He recovered from just to recur again after 2 months, and this time during the 4th episode he was admitted, and we had done the workup, and now we are presenting this. So this is his in a family tree. We can see he has a 4th generation family tree. This was born of a 3rd degree consanguineous marriage. This is when MTP was done, and one of the cousins of these parents had at 10 years of age diagnosed to have a mental retardation, have storage and obesity. We don't have further details on it. On examination anthropometry, he was his growth was normal. On examination, he was lethargic. He has an tachypnea. He has tachycardia. He has cold extremity, delayed capillary filling time. But there was no pala, icterus, cyanosis, clubbing, and edema. On examination, there was no facial dysmorphism, and fontanelles were closed, and no history of any specific body odor. So this on examination, he had a 4 centimeter soft liver. The span was 7 centimeter. And there was spleen was not there. There was no ascites. In CNS examination was lethargic. Pupils were normal size. Muscle tone was normal. DTRs were normal, and those signs of meningitis. Rest of the systemic examination was normal.
We will stop here. First, I will ask the audience and then to our learned panelist. This is a 1.5 years old boy who presented with discrete episodes of intense vomiting. 4 discrete episodes of vomiting. In between, he remains normal. All this episode is to abate after starting IV fluid, 2 to 3 days, and he is gone back to the normal state. No regression of milestone, no neurodevelopmental problem. So, what are the possibilities you can think about in 1.5 years old child? Yes? Recurrent episodes of vomiting. Intense vomiting, he was requiring IV fluid. Said Dr. Goda.
Right, four possibilities I would think. One is obviously onset is a little bit later, 1.5 years.
No, it started at 9 months of age.
Okay. Fatty acid would be there, although ketones are positive in urine with hypoglycemia. Urea cycle again, we would think, but you have got metabolic acidosis where we would get respiratory alkalosis. HFI again, I would think because at that time he would have been introduced to fructose, but you have a child in normal in between. So these are the three possibilities I would think about in this case.
No, nothing. You show the anthropometry is normal, in between is normal, no issue as far as the neurodevelopment is concerned.
Okay, I have just one more.
Yeah.
Can I add to this?
Oh, sure, why not?
There's repeated risks of vomiting. We've seen one patient of fructose 1,6, which these patients remain completely all right in between, and they have no failure to thrive also usually associated.
Okay, now I will come back to our panelist. Dr. Priya, would you like to put forward your view at this stage, or you want more investigation?
I'm actually just trying. So there is mild hepatomegaly.
Mild hepatomegaly.
Repeated episodes
of vomiting.
Vomiting, hypoglycemia with the metabolic acidosis. Do we know if it's an anion gap or a non-ion?
It's a normal anion gap.
It's a normal anion gap. Okay. Right.
Okay. Now, just hold on. As I said that we will go step by step. If I give all investigation, then next 5 minutes we can finish the diagnosis. At this stage, if the child comes to you with these episodes of intense vomiting and found to have acidosis, and then he recovered, absolutely normal in between. So clinically, what are the possibilities we can think about? Then accordingly we can investigate.
These episodes
Sir,
well, I think when we see vomiting, first is the GI, but it's easy to recognize because there will be abdominal distension, recurrent obstruction, mild strain vomit. So straight away take away GI out and get onto a CNS. What CNS? Only two. Raised ICT, if this child doesn't have, it's metabolic. What metabolic? Acquired or inborn? What is acquired? Renal maybe, a liver maybe, easy to make out, failure to thrive, hepatomegaly, whatnot. So inborn, straight away come on inborn. I think when vomiting center gets stimulated, you have every kind of a stimulus in terms of abnormal chemical. And I think that's clear message that vomiting is not GI. Then add on to that recurrent. What is recurrent in clinical medicine? Only two, immune mediated or metabolic. Rest all are not recurrent. Okay, mechanical, we have ruled out. So this is immunological or metabolic. This is not a story of immunological. So metabolic, you straight away come on metabolic even in the first episode of vomiting.
Sir, if I add a little information into this case, what we are telling, absolutely normal child in between. The episodes with absolutely normal child in between.
Allergy and metabolic, okay, what is the peculiarity? Sudden onset, sudden disappearance and recurrence. They are in between normal. Well, they may not be fully normal. They're going down in weight, they're not thriving well, but they have no symptoms.
Besides metabolic, anything else, any of these panelists? Anyway, we'll discuss metabolic, but would you like to keep any other, John?
No.
Since Dr. Priya is sitting here, it must be metabolic.
No, my intention is that as a clinician, if you see a child, will you consider only metabolic or you'd like to keep any other differential diagnosis?
Poisoning.
4 times.
Recurrent episodes, discrete episodes.
Allergies.
Food allergies.
Hepatomegaly is soft, that is probably is
Food
not
allergies.
recurrent discrete episode. We are talking about the intense vomiting discrete episode. In
Cyclical
what other condition?
Cyclical vomiting.
Sir, Professor Amdekar,
Malrotation of gut can also sometimes come with.
I wanted this pediatrician should know that beside metabolic, you can think about cyclical vomiting syndrome also, where you have a intense episodes of vomiting with in between normal. So yes, metabolic needs to be considered, but if you don't keep the cyclical vomiting, so probably you will miss a bus. Dr. Goda.
Is it possible that this, what is known as cyclical, is one of the undiagnosed metabolic?
Possible, possible, but
Since we have started diagnosing it, that cyclical diagnosis becomes less common these days.
Anyway, there may be a difference in opinion, but there is an entity called cyclical vomiting syndrome where it is a purely neurological problem, and they do respond to your, they have an underlying mitochondrial problem. You give glucose, they get corrected, but you can prevent those attacks also by just giving medicine. So this entity is still there, cyclical vomiting syndrome. Not all of them are pure metabolic. Pardon? No, the fever is a stressor. All the cyclical vomiting episode, you will get some kind of stress. There may be a physical stress, there may be a fever, there may be some other stress that precipitates. So you cannot differentiate. So metabolic along with, means as a clinician, I will keep this cyclical vomiting also. Professor Amtekar may...
Lethargy is not a feature of cyclical vomiting.
Sir?
Lethargy is not a feature of cyclical vomiting. They vomit the whole day, you put them on IV, they get out next.
So that happened in this child, sir. In 2 or 3 days, he is up. He is absolutely normal.
Lethargy. Okay, if he's lethargic,
yes.
I think there is an encephalopathy.
See, okay.
That's right.
Yeah, absolutely.
This child has got liver enlargement. So that will take us away from cyclical vomiting.
Right.
No, I am not telling this is cyclical vomiting. I want to give this message that you need to consider, if you have this set of symptoms, so you have to keep differential diagnosis cyclical. Do you agree, my panelists? Will you agree to keep as a differential diagnosis cyclical vomiting or not?
But I think the point is that now, because we've got a history of hepatomegaly and repeated episodes, we are moving in the direction, and hypoglycemia and lethargy, and then
yes, we have many pointed towards metabolic, but I want just to message to give that you need to keep that is a differential diagnosis also.
Go ahead. So we should,
Yeah, so the possibilities we kept cyclical vomiting, inborn error of metabolism, and malrotation of gut with intermittent volvulus, though it won't, we don't have a clinic.
Girish, you want to make a point?
I have to say this, but malrotation of gut with intermittent volvulus will have bilious vomiting.
Yes.
This is non-bilious. Cannot be in the differential diagnosis.
Accepted.
So
that Professor Amtekar already said, GI cause is unlikely.
So,
I have a point.
no, go ahead.
I just feel that failure to thrive not being there, all these 4 possibilities will become less possible.
So what is the possibility? What is the possibility
not
then?
being there.
What is your possibility?
I think there's very few metabolic liver disease which will come without failure.
No, give that possibility.
Fructose 1,6 biphosphatemia is a very mild.
So you want to keep HFI is a one possibility.
Not HFI, not HFI.
Okay.
1,6
I'm talking
biphosphate
of fructose
deficiency.
1,6 biphosphatemia, which is not HFI.
All right. So
is this the order in which you're thinking about them? Is this, you've put it, or you're just listing them?
We have listed. We have not thought of malrotation of the gut. We have not investigated.
Really seriously considering, as already mentioned, he was this child was in between normal, no failure to thrive. That's why we kept the cyclic vomiting as a first, followed by inborn error of
Sure. So now let's relook at this. Can the audience tell us how would you reorder it, given the information that you have?
Since hypoglycemia is there, I would keep the fatty acid oxidation defect above and then bring this down, all these things. Because urea cycle defect will not have hypoglycemia. Organic acidureas may have hypoglycemia, but they have more often hyperglycemia. So that again, respiratory chain defects and fatty acid oxidation defects can have.
They do
both. They can have.
We have a different kind of information in this patient. He has hypoglycemia, he has ketonuria. He has acidosis, so you cannot take only one hypoglycemia as a features and put one diagnosis. So you have to combine all, and then only you have to take in account that what is the first possibility. So if you take everything in account, what will be your first possibility? Hypoglycemia, ketonuria, acidosis, high anion gap? High anion gap.
These parameters have been done
during
at the
attack.
beginning or after 2-3 days of vomiting.
During attacks.
It's somewhere in the beginning, because some of these
During
biochemical
attacks.
changes can come
because of
as
the
a
severe
frequent,
vomiting.
Yeah, because of the vomiting per se. So
Ammonia have you given? No.
Yeah, we got ammonia also. Normal.
yeah, go ahead. I think we
Coming to the investigations, this one was when the child was symptomatic. This was in June and this was in November. We can see that there are AST and ALT are 10 times elevated, but however when the child is asymptomatic, they have completely normalized. In one of the episodes, sodium was high, but you can see it's normal. Even potassium was normal. Lactate was 36. Our lab cutoff was 21. That's an ABG value. Ammonia was 78. upper level is 60, so it's just mild elevated. We had blood sugar which was low, and urine ketones were positive. And one more, then after when we have rehydrated, these ketones were normal as when the child was asymptomatic. So this is an ABG. It is during the 4th admission. We can see the severe metabolic acidosis with high anion gap, and this was after the resuscitation and bicarbonate was correct.
Stop. Now
Blood
we
sugar
take
is
the
low
panel.
means how low? How low is the blood sugar? Very low, or
It was we detected with the glucometer. It was low. That means less than 20.
less than 20?
So,
Okay, Dr.
first-
Priya.
Yeah. So let's actually first talk about what are the causes of an increase in anion gap. I mean, can the audience tell us what are the substances that can give you an increase in anion gap?
Metabolic acidosis with high anion gap. Any?
Lactic acid. What other acids?
Ketoacidosis, lactic acidosis. These are
What other acids can be contributed? Organic acids.
Organic
Organic
Correct.
acids. So now,
Keto acid.
Dr. Priya, can you summarize this investigation panel and give your opinion? What could be the possibility?
Right. So I think the first other key is when we say urine ketones are positive, there's a real misnomer when we say that fat acid oxidation defect is a hypoketotic hypoglycemia. It's a relative hypoketosis to the hypoglycemia. So the presence of ketones in this situation does not exclude a fat acid oxidation defect. I think that's the first message to take. The second is now you've got an increase in these liver enzymes. So what do you think is going on here? Do you think it's important to get anything else, or we are comfortable with this information? So we've got a lactate. Is that?
Yeah, lactate elevated.
Is that?
Lactate is elevated.
Yes.
It's elevated.
Very
Yeah.
Okay. So now we've got
severe acidosis.
ketosis. We've got a lactic acidosis. So what do you think is going on? Right.
Lactate is
So
how much elevated?
mitochondrial disease.
1.5
exactly. So the lactate is not.
No, 3.8 is not the cutoff. This is in between. Our cutoff value is around 25.
Our lab
22
cutoff
is
was
the
21. That is an ABG.
So it is
cutoff.
1.5 times elevated.
And this value was from somewhere elsewhere. We don't know what was the method of this lactic, but they told that this 3.8
No, because
is a normal.
there are different normals for this lactate.
Yes,
There are
sir.
some
Yeah.
labs like
Yes, sir.
ours which give up to 4 as normal.
Oh, so our value is around
21
22,
is the normal.
22 or 25 like that. So it is a
that means
1.5
that
times.
During the episode, the lactate is definitely
Definitely.
high.
Yeah.
We're not sure whether the intervening lactate
Yes.
is actually normal
Yeah.
or
This one
marginally
is
elevated.
normal, sir.
This was normal.
This one is normal.
Normal.
Okay.
So there's just one key message to give here. When we're doing a lactate, the values can be falsely increased depending on, so this is for the pediatrician, right? So if there's a tourniquet that's applied, you're not going to get an appropriate lactate value or an ammonia. The second is it really has to be put directly on
Processed
ice and processed to the
immediately.
lab right away. So now let's say that we don't believe the lactate. What
Yep.
can we believe in this situation to say that it is adding up, the situation, is the presence of this big anion gap. So we know that it's likely ketones, it's likely lactate, or just ketones and the lactate was inappropriate. So if we determine that the lactate was appropriate, now we've got a ketosis and a lactic acidosis. So where is our differential going?
So we enlisted those causes, out of which one is more likely after this panel of
Go
investigation?
back to your previous
Go
slide.
back? Yeah.
Out of
Forget
this,
about
which
the
one?
first and third, concentrate on this middle one. Urea cycle defect, organic aciduria, respiratory chain, fatty acid oxidation defect. Now you have the
Out.
out.
There's
Okay.
normal anion gap there. And normal anion gap.
Yeah.
Fatty acid.
Fatty acid.
Fatty acid oxidation defect, organic aciduria.
I mean, I understand if this is actually blood, ketones done, then this should be, fatty acid oxidation defect should be out also. But you say that if it's urinary, then we can
This is
keep it
urinary ketone.
urinary. So then we can still
No,
keep
but
fatty acid.
we're discussing that severe metabolic acidosis,
So
high
my
anion
problem
gap.
my problem is no failure to thrive at all with all these.
No. Why you are sticking to only one diagnosis? Let us discuss the problem as it is. Yeah. So, Dr. Archana, would you like to
Yeah,
make?
so basically there is hepatomegaly, there is derangement of enzymes, there is high anion gap, there is acidosis, there is ketones, and there is hypoglycemia.
Yeah, exactly.
So there are
Hepatomegaly.
multiple defects.
Yes.
So among these I think mitochondrial one should keep in mind, because, and there is neurological abnormality also. He had
he had one
This child-
seizure, febrile
No, that's a
seizure
finding
with
during
fever,
the episode.
subsequently normal. No, examination wise, there is no apparent neurological problem in this child. Ketonuria in mitochondrial disorder?
with severe vomiting if the urine is collected after that.
How
The
strongly
only
positive was these ketone bodies, or
Ketone
just borderline?
They were
Just
moderate positive.
moderate.
only
So
thing
there is
against
quite a bit.
mitochondrial is the ketones.
Ketones.
And if you consider all these, organic acidemias is a possibility, but I
Yes.
don't know how the elevated liver enzymes.
You can get.
I think it's really critical in this situation that you've done some amount of workup, but you really do need plasma amino acids in this setting, and as well as an acyl-carnitine profile. I mean, you cannot really proceed too much
Okay.
beyond.
So
I think
at
we
least
can only say
hold
what
on.
it is not. I'm not
Right.
sure we can say
You
what
can
it is.
exclude. Right.
Considering the clinical picture and this set of investigation which probably available everywhere, so you can go up to this level. Beyond that, probably you need to refer, but at least you can cone down that there is enough hint that this could be a case of organic aciduria. Am I right? Panelists will agree with
Yes.
me. So there are features to suggest this is organic aciduria. Dr. Priya has highlighted hypoglycemia, ketonuria, high anion gap metabolic acidosis. So if you get this picture with a symptom of recurrent vomiting, think about organic aciduria. Other possibilities, there are many words, right? Shima, right now will not consider your possibility. That is a, yes, no, up to this is fine. Now we'll show the other investigation. Okay, so as a your level, you can do all this investigation. Sir.
So
Okay, we'll go to the
that's
detailed
another-
investigation.
That's
Yes.
another thing I would like to clarify. We always talk about the lactate to pyruvate ratio. It's very good in textbooks, but in reality, to do a pyruvate is a next to impossible task, and it doesn't really take you in too many directions, unless it's done in a sophisticated, situation. So I don't suggest doing a pyruvate in the pediatrician's office or in a primary care setting.
Next slide. No, go to the biochemistry. So you agree that this is possible at your level, isn't it? This is possible at any secondary care pediatrics level. You can do this test, and you understood that reasonably certain you are that you are going into the right direction. So don't get scared with this inborn error of metabolism. So even at your level also, you can do some test and you can get to the correct diagnosis. May not be 100% sure, but the aim of this presentation is that at your level you should do this minimal investigation. This is possible.
I think the
Now
carry
we'll go
home
to-
message is also that organic acidemias are not always continuously symptomatic. They can present episodic. That intercurrent illnesses can provoke a severe
Precipitate.
acidosis. So just
Right.
because it's episodic, do not rule out metabolic diseases with acidosis. I think that's the important message.
You
Yes.
get an elevation in
Organic
Some of
in
it. That we will
organic
discuss.
acidemias, yeah.
So the message
Mild
is clear.
elevation.
So the simple investigation can help you. Now we'll go to sophisticated investigation. Next.
His hemogram was normal. CSF analysis that was done previously was normal. So urine GCMS shows increased secretion of methyl hydroxybutyric acid, acetoacetic acid, and other organic acids. Urine amino acidogram was normal, and carnitine acyl-carnitine profile was normal. We did liver biopsy when the child was well. It was just showing focused steatosis with mild mononuclear cell infiltrates.
So now Dr. Priya.
No, I want to actually take it back to him. What is your GCMS? What is it telling you there?
It's showing some organic acids in the urine. So it's an organic acid. That is the probably that's causing a high anion gap. And and this carnitine profile is normal, and there is no. If you see, urine amino acidogram is normal, so amino acid urea is not there.
When was this done? During
During symptomatic
the
period.
third
During
episode?
episodes.
During the
Third episode when he came to us. Any other thoughts? So it supports the diagnosis of organic aciduria.
Yes.
So do you need any further information?
I would like the plasma amino acids
Plasma
in
amino
this
acid.
situation. Now you've said the acyl-carnitine profile is normal, which kind of doesn't add up. I would have seen at least an elevation in C2 because you said that there's significant ketosis. So this case doesn't seem to add up to me at this level. I don't think there's no elevation in C3, there's no elevation in C4 or in C4 dicarbs, and you're saying that your
carnitine is
normal. So
we are at organic acidureas, or
it seems like you've got methyl hydroxybutyric acid.
Yeah.
So it could be a 3-methylbutyric aciduria, but this is an unusual.
Yes, there is some odds,
Yes.
but after doing simple investigation, you thought it could be organic aciduria, and after doing the urine GCMS, you are still at that point only organic acidurias. Let's have the next slide.
Can I have one comment?
Sir.
There is, I mean, would you agree that there are these acids are features of TCA cycle disorder, Krebs cycle, hydroxybutyric acid and all?
For it to be a Krebs, it could be, but we don't have enough information from the urine organic acid. There's no mention whether citrate is low, or if one of the key lessons really is if you're thinking organic aciduria, you usually get an increase in the methyl citrate and a much lower amount of the citrate. And when your ratio of methyl citrate to citrate is altered, it's very strongly suggestive of propionic acidemia or methylmalonic acidemia. Now, in the face of a normal acylcarnitine profile, it's these, you completely excluded these. Yeah. You haven't shown methylmalonic on your urine organic acid, you've shown a normal C2 and a normal C3. So it looks like to me that your acylcarnitine was drawn when the child was well. It otherwise does not add up with ketones and a normal acylcarnitine profile.
Next thing.
So we have whether it is a fatty acid oxidant defect, we know urea cycle defect is out versus organic acidemia. And we have hypoglycemia but no ketone urea or high ammonia. This is a condition we are not facing here. So we have hypoglycemia with ketonuria, high NAN gap, metabolic acidosis.
So this is a simple message we want to give. Yeah. So it is by going by this simple algorithm, you can categorize that where exactly. You may not be 100% sure, but fairly sure that probably you are not dealing with fatty acid oxidation, but probably organic aciduria. Next slide.
So we kept with this investigation, we kept possibility.
No, that we already discussed. Go to the next.
So what can be the organic acidemia that can be present? See, the first three, propionic acidemia, methylmalonic acidemia, isovaleric acidemia, actually they are very severe. Yeah. Presentation present early in the, also we have to add up the clinical picture along with prior to the interpretation. Here we have urine ketones are very high ammonia, lactate normal, or glucose may be high, can be normal or can be low. Carboxylate deficiency will present with some skin manifestations, so they are unlikely in this case. So if you see the clinical picture, this is HMG coenzyme lyase deficiency, beta ketothiolase deficiency, and also SCOT deficiency. Clinically, they can present with episodic, with the symptomatic episodes with in between normal with no failure to thrive. But this HMG coenzyme A, the ketones will be absent, and beta ketothiolase deficiency, they are positive. Ammonia may be mildly elevated. Lactate we have 1.5 times normal and ever documented hypoglycemia.
I think you really want to sort out in two different, when you're talking of beta ketothiolase and you're talking about SCOT, those are massive ketonuria situations. So you really have to put them in a completely different bucket as compared to where you were. And now when you're talking about these situations, I would really put one more column over there of glycine. These are known to be ketotic hyperglycinemias. So that's something to really take home, is that when you're seeing a situation of ketosis, and a metabolic acidosis, you want to know if the glycine is elevated or not. If it's elevated, it's very suggestive of propionic and methylmalonic acidemia, as well as isovaleric acidemia. So I think these really need to be considered.
Propionic and methylmalonic would have presented earlier, isn't it? Than 1.5 years?
Not necessarily, depends on the genotype of the patient. And sometimes they can present a little later. You're right, they typically do present earlier, but I'm imagining that this is a milder variant of something.
You didn't use any vitamins or carnitine in the treatment.
We didn't discuss. Do you have any information how to go about this treatment part if you have a organic aciduria?
Yeah, for this, in this child, when this child was symptomatic, we have hydrated him well, treated the acidosis, we have given a dextrose. 10% dextrose that we have used, and we have hydrated well, and we can see in 7 to 8 hours this child has shown the symptomatic improvement, and he had good glucose control. We actually have not yet started him on a carnitine, though, because we don't have a specific diagnosis at this stage. We just started him on low protein diet, and
so there's only one message to give you is even while you're waiting for a diagnosis, carnitine is non-toxic except in a situation of LCHAD, where if you've got supranormal levels of carnitine, and here we've pretty much excluded LCHAD or a fat acid oxidation defect based on it. So I think just giving IV dextrose is not good enough. You've got to give the carnitine to mobilize the fatty acid cycle and to be able to excrete out propionyl carnitine or methylmalonic, whatever it is. Without the presence of carnitine, you can push this kid into an encephalopathy and not being able to come back. So to me, that's one simple message. When in doubt and you're thinking metabolic, give carnitine.
We are running out of time. Thank you, Dr. Priya, Archana, and John. Thank you, everybody.